Hello, I'm Dr. Hector Villaraga, cardiologist in the Department of Cardiovascular Diseases in Rochester, Minnesota with the Mayo Clinic. In the next 10 minutes or so, we'll be talking about a topic in cardio-oncology. So the title of my talk is, what is the big picture in cardio-oncology? What tests to follow the patients with and what drugs to use? And what's happening is that the prevalence of the U.S. population by age for the year 2040 is going to be the majority of them. Good percentage-wise, around 25% are going to be over 65 years. So there's an increment in the aging population. If you look at the line, which I'm showing more or less where the mouse is at 2020, you can see how the percentages are lower, and it's around 16%. So that accounts to 17.5 million. But for 2030, it's going to be about close to 30 million. And why is this important? So as we said before, the aging population is increasing. By the year 2060, about 25% of the population is going to be over 65. The mortality is decreasing while the survivorship is improving. And this is due to new chemotherapeutic drugs, new agents, earlier diagnosis. So this means that we're going to have more survivors as time elapses. And what are the majority of these survivors? So if we look at this pie chart, which could be a little old, we know that the majority are going to be over the age of 65 or 42 and above, and 2/3 are going to be elderly. So we're going to have in this big pie, almost 95% of patients are going to be middle age or above. And if we were to stratify this by cancer site, the majority of the cancers that can produce cardiac toxicity or cardiac damage are going to be patients with breast cancer and hematologic cancers as lymphoma, non-Hodgkin's lymphoma, or some types of leukemia, or a high lifetime cardiotoxicity risk of 5.3 million. And that was around 2014, which will be increased as the decades pass. So how does cardiac toxicity defined? Cardiac toxicity is defined by a drop of 10% of your EF to a value less than 53%. This was one of the criteria. The other criteria developed by the European Society of Cardiology was a drop of 10% to a value less than 50. So that means while you're being monitored with echocardiography or any other method, if you drop your EF by more than 10 points to a value less than 53 or less than 50, we say that you have cardiac toxicity. So how does this tie up? Well, besides cardiac toxicity, then will be the development of heart failure. And what we saw in a study here in the Rochester Epidemiology Project is when we took 900 cancer patients with 1,500 controls, we looked at the incidence of heart failure. And as you can see here in the left side corner, which I blew it up here, you can see that the curves diverge, being the heart failure patients from the get-go, from the year 0, year 1, you can see a divergence of curves. So there's higher incidence of heart failure in the cancer population, again, in this case by breast cancer and lymphoma, when compared to controls. And what were the main risk factors for this? Were patients with diabetes mellitus, as you see here, diverging curves immediately, and a dose of anthracyclines greater than 300 milligrams per meter squared. So we have around an incidence of heart failure in this population of 7%. And an incidence in the control population of around 3.5%. So it's not everybody that has heart failure, but you can see how the curves diverge from year 1. So that's why it's important to define cardiac toxicity and then heart failure. So this is related mainly to anthracyclines. How about trastuzumab, which is another common medication used for patients with breast cancer and some esophageal cancers? In this study of more than 10,000 patients randomized to trastuzumab, there was in about 11% of patients an EF drop of greater than 10%. That was reversible. And patients that developed heart failure was about 2.5%. So it does happen. It's not huge, as I showed you in the previous slide and in this one, but we have to be very tuned to it to diagnose it in our population. So how do we have to monitor these patients? So the mainstay of the treatment is to monitor the ejection fraction by different methods, but this is the left ventricular ejection fraction, how the heart is pumping. And it can be by echocardiography, cardiac MRI, or nuclear medicine called MUGA. And I will show you some slides about this, but the advantage of echocardiography, which is the one that we most use here at the Mayo Clinic, it's because it's portable, not radiation, not ionizing. You can do a limited study, and you can look at the valves and the pericardium as well. So in this study, where they compared MRI to MUGA, which is the nuclear medicine, and echocardiography, they compared the three modalities in the same patient for 1 year. So these were 90 patients recruited. They had to have 3 EFs with 3 different methods at baseline, at 6 months, and at 12 months. And as you can see here, the correlation with 3-dimensional EF by echo versus MRI, you can see the correlation is very nice, above 0.9, with box plots that show that it's not very different between one method and the other. When you compare MUGA with MRI, the same scenario, you see that correlation is great. Here is about correlation about 0.88, which is very good also. And when you compare MUGA with echocardiography, you also see a nice correlation above 0.85. So any of the methods here is very good to monitor your ejection fraction or the patient's ejection fraction while he's undergoing cancer therapy. We traditionally use here, again, as I said before at the clinic, echocardiography. Okay, so let's exemplify this in a couple of cases. The first case is a patient, 49-year-old female that had breast cancer in 2004. At that time, she had radiotherapy, chemotherapy with anthracyclines and trastuzumab. And in December of 2013, as you can see there, she has all the symptoms of heart failure. She was started on guideline-directed medical therapy, and when she came to us, she was in frank still heart failure. And this is her ventricle. As you can see in this short axis view, definitely it's not a happy ventricle. On the contrary, this is a 63-year-old male with new diagnosis of lymphoma, past medical history of hypertension, diabetes. Physical exam was unremarkable, and this was his ventricle. Same cut, but as you can see, this is a very happy ventricle. So probably if you were going to decide in which of the two you would like to have prevention is on case number 2. Because in case number 1, the patient subsequently went to heart transplant and is doing quite well, but probably we would like to intervene before the ventricle falls. So why is this important? Because definitely more malignant than cancer is the heart failure that develops because of the treatment. If you look here in this curve, which is a little bit old by now, but patients that survive with doxorubicin therapy is more or less the same as patients with ischemic heart disease or with infiltrative myocardial disease. So definitely you want to intervene up here in the top left-hand corner when the patient is under treatment and you detect cardiac toxicity. And what happens if you do biopsies to these ventricles that have received, in this case, anthracycline? And if you define that a greater than 2.0 grade of biopsy already has damage to the myocytes, and you do a biopsy to them, this is what you see. You start seeing replacement fibrosis or patches of interstitial fibrosis in the myocardium that when you look at the EF of these patients in this study by MUGAs or by echocardiography, the EF is still normal. So even though EF is a great parameter to follow the patients, we have to go beyond the EF to be able to define earlier cardiac toxicity and intervene, as I will explain at the end of the talk. So what was happening before? Oncology and cardiology were looking at different horizons. They were each taking care of patients, but without talking to each other. Now the field of cardio-oncology brings us together. They came together and we're looking at the patient from the same place to the same horizon to protect their heart while they receive their chemotherapy. And since I told you and we discussed that the survival is better, now we have to take care of those hearts. So it's not the heart that takes the patient and defines its prognosis. So this is where advanced cardiac imaging comes in. And I'll show you an example of that as well. So this is the case number 2 where I showed you the lymphoma patient. As you can see, a happy ventricle. And we did the strain imaging on this patient at baseline, super nice curves, everything. So what we do here is we divide the ventricle into 16 segments and we look at each segment, how it deforms, which gives you one curve. And then we looked at the sum and the average of all the curves and we come with a number. And this is what happened to the patient after cycle number 3. So as you can see, when I compare with the baseline bullseye, it was perfect. And then cycle number 3, we had already changes in the strain values with a normal EF. So that's a signal that as cardio-oncologists, we should trigger us to do cardioprotection in these patients to avoid a more significant drop in ejection fraction later or a development of heart failure. And I'll present you some slides about the use of strain. This is a meta-analysis which showed the same clinical scenario of a patient that at baseline had a normal EF but with normal strain. EF dropped a little bit, but the strain dropped more than 3 percentage points. And if there was no intervention here, then the EF was going to continue to drop. What does the study show us? The different ways you can cut it, either a 2% absolute decrease or a 0.8% decrease, or a change in GLS, global longitudinal strain with positive troponins. It can give you different sensitivities and specificities that can tell you that the EF is going to drop down the road. And this is, again, same clinical scenario with different cutoff values of drop in strain, of troponins, or a combination of, and gives you different sensitivities and specificities for it. And how about in this case, immediately after anthracycline therapy in acute patients, same clinical scenario, EF is within normal range, but there is a significant drop with a nice sensitivity and specificity. So definitely we do have the signal, and we have to pay attention to it. Again, here, same scenario, different drops, and you can see very nice in this article sensitivities and specificities. And here is more or less the sensitivity and specificities of it, between 79, 80, or 70, but still not 100%, but in medicine, we don't have techniques with 100% sensitivity and specificity. Here in lymphoma patients, in green, the EF, which did not drop until 12 months after. And you can see here that there was an early signal in this cases of breast cancer that receive anthracycline and trastuzumab. There was the signal by different types of strain that the EF was going to drop, and this is where you have to intervene. Sensitivity and specificity, 73 and 92% respectively. And here in lymphoma patients, 4 time points, EF dropped at the end after 12 months. And again, you were having the signal before 6 months after the completion of the first rounds of chemotherapy that the EF was going to drop. That makes us say, hey, we have to do something here with this patient. He can continue his medications, his chemotherapy, but probably we have to cardioprotect that heart. So what is the appropriate monitoring these patients? And this was just an expert consensus for what to use in these patients. It was directed to multimodality imaging with an emphasis in echocardiography. So what do we do? So when you're having a patient that will be initiated mainly in anthracyclines, and there are other types of chemotherapy that have type 1 toxicity, but let's keep it simple to type 1. Toxicity, mainly anthracycline. You do a baseline echocardiogram. Could be with 3D EF, but 2D can be also done. You do global longitudinal strain and troponin. If you have a low value of this EF, less than 53, or you have an abnormal value of strain or positive troponins, you do a cardio-oncology consultation where your cardio-oncologist will sit with the patient and talk about the pros and cons of therapy and cardioprotection. If the value is normal, EF is normal, strain is normal, negative troponins, you do one after you complete therapy and then 6 months later. There are other societies that do this up to 1 year. We also use the anthracycline-induced cardiotoxicity clinical predictors. So if the dose is going to be greater than 240 milligrams per meter squared of doxorubicin, the type of administration, if the patient is going to have chest radiation at the same time, or if he's younger than 15 or older than 65, or he's a female, if he has pre-existing cardiovascular disease, hypertension, or African American, you have a higher likelihood of having cardiac toxicity. So here you have to probably monitor this patient more closely. How about if you're going to initiate trastuzumab after the patient received anthracycline? So again, do another echocardiogram, which could be the 6-month echocardiogram if you have finished the previous therapy. If it's below, again, 53% of EF or low global longitudinal strain of positive troponins, cardio-oncology consultation. If it's normal there, you do it every 3 months as long as the patient is having trastuzumab and then 6 months after you finish. So there is a way to continue following these patients that are having trastuzumab after anthracycline, again with echocardiography. So how about if you're just going to initiate type 2 toxicity chemotherapy agents as trastuzumab, as VEGF inhibitors, TKIs? You do, again, the same baseline evaluation with EF, troponin, and GLS. If it's lower than the values I have talked about before, you'd have a cardio-oncology consultation to discuss about cardioprotection. If everything is normal, you follow up at the first month when you have TKIs on board or VEGF inhibitors, then every 3 months during therapy. And these TKIs and VEGFs are mainly some lung cancer patients, GI cancers, melanomas have these medications, or some patients with lymphoma that have combination chemotherapy. Again, we have also trastuzumab-induced cardiotoxicity clinical predictors, which are similar to the anthracycline ones: prior chest irradiation, prior anthracyclines, age, hypertension, diabetes, coronary disease, cardiomyopathies, and atrial fibrillation. So here I have shown you 2 different models of trastuzumab with other type 2 chemotherapy agents, type 2 toxicity, or type 1 mainly anthracyclines, how to look at factors in the patient that could increase the risk for both of these type of toxicities. And what do we use here at the clinic? We use this Mayo risk prediction model, which we give a score depending on the type of chemotherapy that the patient is going to receive and 1 point for each risk factor that the patient has. And we classify the patient from very high risk to very low, and we cardioprotect or follow the patient closer with echocardiography during their treatment. If we're going to ask what medication should be used, I know this is a very busy slide, but I just wanted to highlight dexamethasone, which is mainly used in the pediatric population, not a lot of experience in the adult population, but excellent cardioprotection. This is mainly for anthracyclines. This works in the mitochondria with the chelation of iron, but not a lot of experience in the adult population. Beta blockers may be mainly carvedilol, bucindolol, 69% reduction in cardiotoxicity prevention, excellent. Statin as well, mainly atorvastatin, again, a good reduction in cardiotoxicity, and ACE inhibitors as well. Which ones do we use? I'll show you in the next slide, but what I want to show with this is, let's say the patient, his blood pressure is 100/80. Then we don't have a lot of options. We can either start carbidopa at a dose of 3.125 at night and then BID, or you can start the patient on a statin. If the troponins were positive, so there is a leak saying there is some cardiac damage, we favor lisinopril. Others use ramipril for this. So in summary, for cardioprotection, ACE inhibitors, lisinopril, ramipril, beta blockers, carbidopa, bucindolol, statins, mainly atorvastatin. But don't forget exercise. And this exercise has to be with a grain of salt. If you're with a patient that is feeling very bad, very fatigued, chemotherapy has been very hard on that patient, it's going to be very difficult to ask the patient to exercise. But if you see the patient now gone through the chemo, is better and more willing to do, just incorporate it. It's cardioprotective as well and will do great for the heart. So in summary, evaluate patient early before starting treatment with the integrated team. Work all together. Remember that cancer patients share cardiovascular risk factors. And we definitely use echocardiography here because it's one-stop shop that can provide all the information needed. Basic imaging can check for valve disease, pericardial disease. We do advanced imaging with global longitudinal strain. And with this, I want to conclude and just want to show the whole team available here in Rochester. This is our super group of nurses that work with us and also our nurse practitioner, Liz. And this is all your medical staff that takes care of you here or that you can refer to us, the patients. So the take-home points, don't forget, survival is increasing in cancer patients. Cancer patients share common cardiovascular risk factors. Adequate surveillance is the key to anticipate and treat the drop in EF or a drop in GLS and avoid developing of heart failure. And with this, I thank you very much for your attention.